safe to lump them in the same category as IBS?
Sorry, could you just repeat?
Can you say that one more time, just about without the pain component? Is it safe to lump them in the same category as
Abdominal bloaters and patients who come to our office with visible distension.
Yeah, this is a really important issue because IBS is, if you talk about IBS, you can use the Rome definition, but we're a lot less specific about it. People who have bloating, the low FODMAP diet is fantastic for pain and bloating. And they're the things that it really works very well for. And there's very few therapies actually help bloating more than a little. So it works in functional bloating. It works in functional abdominal pain, and it it doesn't always work, of course, but it is effective. The other thing is that there's emerging data that it actually FODMAPs will induce symptoms of functional dyspepsia, although there are currently no trials done in that population of actually reducing the FODMAP intake.
Great. Any other questions? Looks like we have one in here.
With FODMP, so many components to the diet, it makes it relatively difficult, I understand, for the patients and finding a good dietitian to implement and carry out the success. You think in future there is anything in the horizon that we can be more selective in getting FOD and MPs?
Yes. We'd like to be able to select people, and that's where there's a lot of work being done looking for responders, but we haven't been able to separate people out well in that way. But the issue that a lot of people think the diet is very difficult. It does seem difficult from a gastroenterologist sitting back there who's not used to this, but patients really do very well. There was one study from New Zealand where more than 60% of patients found the diet easy to incorporate into their lifestyle. And what, if any of you know anything about Australia versus New Zealand, we say that if 60-odd% of New Zealanders can do it, then probably about 90% of Australians can do it. But we love New Zealanders, of course, but it's not as hard as you might think. But it depends on how it's being taught, because our dietitians teach it so well, and I'm surprised at how well people retain the knowledge about it. Because funny enough, they don't listen to us very much. They only listen to the first few words we say. They seem to listen to the dietitians.
Please go ahead.
It seems, going back over 40 years, we started looking at different etiologies for Crohn's and UC, trying to figure out the basic mechanism of why we got each of these diseases, and yet we're seeing more and more that the treatments are identical. Have we learned anything about the etiology or the difference between these two basic diseases, or are we just working on the end stages of anti-inflammatory medication?
I think to some extent we are really struggling, and I think with the advent of genetics, we thought we would have really dramatic changes in our understanding. I think the genetics has sort of suggested that it's a lot more complicated than we thought, that there are roughly 200 different genes involved, and even if you cluster the genes, there are roughly 5 or so different clusters which correlate with location and phenotype, but there's a lot of overlap. And I think essentially what we're finding, the deeper we dig into mechanisms, is that it's a lot more complicated than we thought. There are some primary pathways, and I think that's the biggest benefit of genetics, is identifying pathways like IL-23 that we hadn't necessarily identified, and the JAK inhibitors and NF-kappa B. But I think, one, the differentiation between UC and Crohn's is pretty crude, and that most pathways will appear in both. And our best understanding is that eventually, hopefully, we'll get to the point where we can say, for you, the IL-23 pathway is really important. This is the category of medicine you should be on. I think we're somewhere between 5 and 10 years away from that, though.
I can add to that. Interestingly, I often tell people this is a multi-million-dollar question, and the reason why is because millions of dollars are being invested into research to try to identify the etiology or the trigger mechanisms for why we're actually seeing this rising incidence and prevalence of Crohn's disease and ulcerative colitis in the world, not just in places where it's usually most prevalent, but also in places now where it's actually less prevalent and becoming more prevalent. And part of the thought is, in addition to the genetic factors are potential environmental triggers, and we have yet to identify what those particular triggers are. And it may be that it's not just any one trigger, it's multifactorial, but at the same time it's also the interaction between what we are exposed to in our environment or what we do in our lives, interacting with the underlying genetics that we have in ourselves. But we cannot actually necessarily wait for all of that before we do anything. And that's why a lot of the thrusts in terms of trying to do drug development and trying to identify novel therapies is to say, what can we do here and now with what we understand about the inflammatory process to help these patients? There are things that are still also tried in terms of, let's say, microbiome manipulation and looking at other ways to modify our disease triggers or in the path of pathogenesis, but so far they haven't panned out as well. So that's why there is what is a seeming discordance between what is actually being studied from a therapeutic standpoint and what we're trying to glean from the pathogenous standpoint.
I think there's also some really good news in that there's now big studies going on trying to look at early factors in these, like the GEM study in Canada, and there's a big study in the UK looking at all sorts of factors that might be involved in people at risk. And hopefully they're going to come out with a little bit more getting to the cause of the problem rather than just treating the consequence of the problem, because I don't think inflammatory pathways is ever going to cure, knocking that is ever going to cure established Crohn's disease. Our best hope is that we can prevent it by understanding the pathogenesis and the trigger factors.
And I worry a little bit. I think GEM and PREDICT are fantastic initiatives, but I worry a little bit that some of what we're looking at, as Berkeley alluded to, is a changing environment, that we know that air pollution and particulates dramatically stimulate the immune system and do seem to have an association. It's really striking. If you schedule a flight for Beijing, you really don't want to schedule it in the late afternoon because there's a decent chance the airport will be closed because the pilots can't see the runways. It gives you an idea of the level of particulates. At the same time, IBD is rising incredibly rapidly in China. And I think it may be really hard to tell without looking over time of how we've changed our global environment. And the effects on many autoimmune diseases, including asthma, seem to correlate with air pollution and all kinds of stimuli to our immune system that didn't exist 200 years ago.
Fantastic. Thank you so much. Thank you.